Good day, friends, and a warm welcome to this edition of Dr. KK's Med Talks. The battle is over. We seem to have defeated COVID-19, but the war is far from finished. Even post-COVID-19, newer and newer complications crop up, and management remains important. It remains essential to medical care, to COVID care. In fact, it's even more important to manage a person post-COVID in a better way than pre-COVID, than during COVID. There are many reasons for this. There may be metabolic issues, there may be psychological issues related to post-COVID therapy recovery. But one of the major challenges that we face is management of pulmonary health, especially COPD and atypical pneumonia. Whether a patient has had COVID-19 in the past or has not had COVID-19 in the past, it is always difficult to manage COPD. The lungs are important, lung health is important, and never in human history has this been brought into such stark focus as it has been in the past couple of years. My name is Dr. Sanjay Kalra. I am an endocrinologist from Karnal in Haryana. Today, after 1.5 years, Karnal has become COVID-free, my district. I hope that we remain that way. And the credit for this goes to healthcare professionals from across the district, across the state, across the country. And it's a great pleasure to invite our special guest for today, Professor and Head of the Department of Respiratory Medicine at King George Medical University, UP, Dr. Suryakant. Welcome, Professor.
Sir, thank you.
Professor Suryakant is also a member of the governing body of AIIMS Patna, and he's a member of the Executive Council of the Uttar Pradesh Medical University at Sci-Fi, Etawah. Sir, warm welcome to you.
Thank you.
We've always known that COPD, chronic obstructive pulmonary disease, exists. We've learned about it in pathology. We've learned a little bit about it in pharmacology, and then also in internal medicine and when we practice respiratory medicine. But for the general practitioner, could you tell us what is COPD and has the definition changed in the past few years?
Yeah. Actually, COPD is a full form. Its a full form is chronic obstructive pulmonary disease. And as its name suggests, basically it's a chronic airway disorder. It's not an infectious disease. It's a non-communicable disease. But it's a very important disease, especially it is said that 40 plus years of age is the more vulnerable age. But in India, if we of course evaluate the age profile of the COPD patients, then 30 years plus it can be a risk factor for the COPD. And COPD is basically, it's not a disease confined to the lungs only. In comparison to asthma, which is totally confined to the airway, and it is usually genetic in nature with genetic predisposition background with some allergen exposure. And these two things causes asthma. Usually presentation is early childhood. In contrast to it, COPD is usually 30 plus presentation and usually more common in males, and it's a systemic disease. First time 10 years back, it was noticed that manifestations, they are not only confined to the lungs, but they are also beyond the lungs. So every system of the body can be involved. So now to understand the concept of COPD, because if you go in the integrity of that definition, it's every year it changes. It doesn't mean anything. But to understand the concept of COPD, one should understand that it has got pulmonary manifestation, it has got extra pulmonary or systemic manifestation. And what is the natural history of COPD? Usually patient is a smoker or exposed to some noxious particle or gases. Now we have to understand, we have published 3 papers now where we say that the importance of non-smoker COPD in this country. 20 years back, in the late 20th century, usual concept of the European Respiratory Society, American Thoracic Society was that COPD means chronic exposure to smoking. But in India, a lot of researches was done, a lot of reports and publications published, including 3 from our department. And they say that roughly 50-50 is scenario, maybe even more than that, is smoking COPD and non-smoker COPD. So The risk factor for COPD are, yes, smoking, yes, one on the top, yes, no doubt about it. 50% contribution is smoking. Number two, the non-smoker is the passive smoking, very important. In this country, the 12 crore are the smokers, and roughly 3 to 4 times they are the passive smokers. So when you inhale the smoke, when you once smoke, the 30% of the smoke going in his lungs and rest of the 70% going to the neighbors, to the friends, to the family members, and some of them it remain in the environment as an environmental tobacco smoke, but it is all harmful. So of course, passive smoking is also important factor. Air pollution. Recently, a report published that out of the top most 30 most polluted cities in the world, 22 are in our country. So air pollution is the second most non-smoking criteria, and third is the biomass fuel. And thanks to Prime Minister Modi, that with this Ujjwala Yojana in Ujjwala 1, of course, he gave the 8 crore poor families with this LPG connection, and now this factor is going down. And so many occupational factor in this country. I used to say from bhatti to bhatta. What I mean from bhatti to bhatta, आप किसी भी सड़क पे चले जाइए, it may be a highway or it may be a you see any expressway, and besides this छोटी छोटी दुकानें हैं जो भट्टी पे जला के कोयले से लकड़ी से छोटे छोटे चाय समोसा तल रहे हैं, छोटी छोटी दुकानें हैं, and this kind of I used to say bhatti, and from bhatta the brickwork and so many other occupations. We have so many innumerable occupations which releases noxious particle and gases and which are responsible for this disease COPD. Now, if you see the natural history of COPD, first symptom is called early morning cough. So anybody during the brush is coughing, it is the first alarming sign, phagic symptom of the COPD, that is called usually morning cough. Previously, it was called a smoker's cough. Now it has caused maybe the smoker or not a smoker. But the early morning cough during the brushing, it is the first alarming sign. Then later on, it gets associated with some expectoration. Initially, it is associated with change of season and winter season, and later on becomes a perennial thing. And later on, it is accompanied by shortness of breath. And later on, there are a lot of extra pulmonary manifestation, including the heart complication in terms of the cor pulmonale, and a lot of the psychological manifestation, anxiety, frustration, insomnia, weakness, cachexia, and of course, bone loss, mineral loss, so many manifestation, and so many other risk factor of heart disease, risk factor of stroke, risk factor of diabetes, so many other. Usually it's a very complex disease. So one have to examine the COPD patient in terms of toto, not only a lung disease.
So this is the message that we get from you. Asthma is limited to the lungs. Asthma will have an onset at an earlier age. COPD is systemic. It might begin just with early morning cough, but it will have systemic ramifications. And usually it begins above 40 in other countries, but in India you might have it at age 30 also.
Early age.
Yeah.
Because
And
in
smoking is
meantime,
not.
this country is starting off smoking is around 18 years. So even the 12 years children in the village, they smoke bidi.
Is it only BD or tobacco smoking which is a predisposing factor for COPD? What about pan chewing, betel nut chewing?
Actually, tobacco directly is not associated, but what happens usually if you see the social gathering, so smoker, pan chewer, tobacco chewer, they are in groups. पान की दुकान पे चले जाइए तो आपको एक तरफ बीड़ी सिगरेट पीने वाला मिलेगा, एक तरफ च्युइंग करने वाला, एक पान बनवा रहा होगा. So usually they get passive smoking also. Tobacco chewing and pan chewing itself is not a risk factor for COPD, but the passive smoking is a risk factor. And of course, if they are related with occupation, small occupation. For example, if you are working in a stone cutter industry, if you are working in a khanan, if you are working in a for example, you see cities like Firozabad in our Uttar Pradesh, they are very famous for chudi, bangles. And in every, you see the gully and market of the Firozabad is full of the production. Every house is involved. The small children, they are involved in bangle industry. So छोटी छोटी जो चूड़ियां बनती हैं उसमें काफी धुआं निकलता है. A lot of, so any occupation that releases the noxious particle, smoke or any of course gases like this, so they are all vulnerable for and of course overall above is the air pollution.
This reminds me of something called guilt by association. This is a legal concept. guilt by
Yes.
association. This is something that is
Yes.
discussed these days also when we are talking about
Yes.
drugs and about who is consuming drugs and who is associated
Very
with
hot
whom.
topic. Yes.
But so then
Yes.
COPD is also guilt by association. Even if you don't
Yes.
smoke yourself, but you are associated with
Yes.
people who smoke, then that is a risk
Yes.
factor.
That is the
Dr.
respect.
Surikant, you did
Definitely.
speak about the
Yeah.
difference between COPD and asthma. And
Yeah.
in English, I have understood that. But in
Yeah.
Hindi, uh, asthma is Dama. In Kannada, it is Damu. Our friends
Yeah.
in West Bengal call it Hafni. And in Tamil
Yes.
Nadu, it's Swasakasam. So all words
Yeah.
are easy to understand. How do you
Yes.
explain to your patient in
Actually,
vernacular
Indian Chest Society has
asthma
given a
versus
resolution.
COPD? Yeah.
Indian Chess Society has given a resolution, has taken a resolution that now onwards we should not, you see, the at least medical fraternity will should not use these terms, the local terms, the modified terms. We should use one term only, that is bronchial asthma, because even a one entity called cardiac asthma, that's a different. The cardiac asthma because of breathlessness because of the cardiac innovation. So simply we use sometimes the people use allergy, sometimes hafni, sometimes dama, sometimes so many other things. So many you see in different languages, different regional and local regional. You see languages they are different names. But one should you at least medical fraternity should resolve that we should use one term that is bronchial asthma. And I used to say different that usually बचपन में सांस फूल गई तो अस्थमा और बचपन में सांस फूल गई तो COPD. Usually this is my single liner to convey. Usually when you start the smoking around 20 years 15 years, most of the time youth they start at 18 years or so, and after usually 10 years or so, or exposure to any occupational exposure or air, or any exposure to the the particles, the smoke and other noxious particles. So after 10 years, people start smoking. But in this country, the mild cases they are not considered as a usually हमारे देश में तो भाई ससुर भी घर में आता है तो खांसता हुआ आता है कि बहू जो है पर्दा कर ले. तो इस दे अभी आप जाइए हरियाणा राजस्थान और वेस्टर्न यूपी में यूजुअल प्रैक्टिस. So whenever, so cough is not considered as a symptom of usually any illness, severe illness. They said
Yes.
cough is a cough. A patient may cough, no problem. So usually
But this,
early disease of COPD and mild disease, they are not being diagnosed, they are not presenting to the doctors. So इसीलिए हम कहते हैं कि बचपन में सांस फूली तो अस्थमा और बचपन में सांस फूली तो COPD.
so that's a nice clinical pearl. To that, please allow me to add that if this onset of breathlessness occurs at age 60 or 70, then it is most
Yeah.
probably a cardiac lesion. It is
Yes.
a cardiac etiology, usually not a
Or it
respiratory
can be
one.
interstitial lung disease also.
We spoke of COPD, and you mentioned that early morning cough is maybe the first
Yes.
symptom. But you
Yes.
have acute exacerbations also in COPD.
Yes.
So, in
Yes.
your practice, how frequent is acute exacerbation in the average patient? And what is the clinical
Yes.
presentation?
Yes. So in this country, if you see the every breathlessness, if at all it has been suspected due to lung in origin, it is by and large considered as asthma. So COPD is sometimes also labeled as asthma, and usually at the level of general practitioners, it is not customary to differentiate whether asthma or COPD. They say, what is the difference? I have to give the inhaler to asthma, also I have to give inhaler to COPD. But I would emphasize through this Med Talks, thank you, Dr. K.K. Agarwal, sir, of course, late Dr. K.K. Agarwal, who has given this wonderful opportunity to interact with the general physician of this country. So, because we have to build up these sensitization and capacity building of these general physicians, because why it is important to differentiate between asthma and COPD? It is important because by simple inhalation therapy, if the patient is taking regular inhalation therapy, there will be no exacerbation in asthma. More than 95% cases of asthma will be well controlled. There will be no problem. But in COPD, even if you are taking the inhalers regularly, you are bound to have exacerbation because of so many reasons. Because COPD is not simply a disease of lung, it has got non-pulmonary manifestation also. Number one is as the disease advances, you will have lung manifestation, then cardiac manifestation, then systemic manifestation. There are so many other manifestations, including psychological and psychiatric manifestation. So
So,
a very multi-systemic disorder. So I think we have to differentiate why asthma and COPD, because in asthma, your management should confine to the airways only. While in COPD, you have to think of management airways as well as beyond the airways. You have to think of evaluation, because simply if you do the chest X-ray, you can find the tubular heart. You can find the cardiomegaly. There are two situations. One side, it may be tubular heart because her lungs are hyperinflated. Lungs are not hyperinflated in asthma. Lungs are not damaged in asthma, but in COPD, lungs are hyperinflated. They are not in normal size. The every breath you take, some retention of air is there, and continuously there is enlargement of the lungs. So if you do chest X-ray, X-ray is normal in asthma. While in COPD, there is a hyperinflation of lung, more blackening of the lung. You will say the intercostal spaces are widened, diaphragms, they are flattened, and heart has become tubular. This is one scenario. And this is called mainly emphysematous pattern, because COPD can be divided as a mainly emphysematous disease, mainly chronic bronchitis disease, or a mixture of two. So there are three phenotypes. Mainly mainly emphysematous disease is called pink puffer syndrome. And mainly chronic bronchitis disease, which have more chances of pulmonary heart failure, right side heart failure, and there is usually pedal edema and cyanosis, and that's why person appears blue, and that's why it is called blue blotter syndrome. Blotter because of swelling, because of edema, because of anasarca, and blue because of discoloration of skin and because of the cyanosis. So it is called blue blotter syndrome. And third is the combination of two. There can be three phenotypes. So I think if you see the chest X-ray, either the heart is tubular because of mainly emphysematous disease, where there is a loss of lung anatomy in terms of loss of alveoli, interalveolar attachment, and so many other things. Even the small vasculature is also damaged. So it's a arterial. It's a not only it's not only airway disease, but it's a vascular disease. It's an interstitial disease and disease beyond the lungs also. So and
So we have, sir, we have
yes.
many people logged in, and Pinky Gosalji, I think, has put in perspective everything that you have taught us today. She had COPD earlier; she is feeling better now, but then she developed GERD, and she has also
Yeah.
got swelling of both legs. She does
Yes.
have cough daily in the morning for the past 10 years, even though nobody at home
Yes.
smoked. So, like you said, multiple etiologies, and now it has become a systemic
And there is a
syndrome.
definite explanation for Dr. Kalla. Why?
Yeah.
Because diaphragm is going down, so there are more chances of GERD. So that's why you have to change the diet pattern. You have to take the early dinner. You have to become from Sharma, Verma, Gupta ji to the Jain. Why I'm saying adopt the Jainism? Because in Jainism, you people take food before sunset. And this is a very hygienic practice for every disease. If you take your dinner before sunset, it's a very important dietary pattern for any prevention of any disease. So diaphragm goes down. That's why there is a lot of chances of GERD. And if you're taking late dinner, that's also a good reason for the GERD. And the second thing, which you said, swelling over the pedima, over the feet, that is indicated of right heart failure. So I used to, make a joke to my cardiologist friend. Dear cardiologist, you are only 50% cardiologist. I'm the pulmonologist plus 50% cardiologist also. Why? Because right
The
side
right
of
side.
heart we are dealing with, only you are dealing with the left side of heart.
So, Pinky ji, if you actually have swelling in both feet, maybe it would be a good idea to visit your physician. And if they advise an echo or any other test, please get that done. But easily they can help you. Uh, no gastric medicine is working, Pinky ji says. So, I think it is the dietary pattern which needs to change. And maybe after each meal, just go for a walk for half an hour. Don't sit down or lie down immediately. And the best part, Dr. Suryakant, Pinky ji is Jain. So, maybe, so
Great, great.
maybe we need to
So you
we need to
enjoy
just.
religiously the Jainism, and you will be
Yes.
okay by GRD at least.
Yeah.
One problem will be went off.
Now, when we have these acute exacerbations of COPD, usually we use antibiotics. The question is, Dr. Suryakant, why can I not use ciprofloxacin or levofloxacin or any other
Yeah,
quinolone?
very
Yeah.
good
What is
question.
the
You
issue?
see, very important question. In this country, actually, tuberculosis is more prevalent. And that's why the guidelines which we made on the banner of Indian Chest Society, along with the National College of Chest Physicians, fortunately, I was the president of both association, and these guidelines were made when I was the president of Indian Chest Society. So during these guidelines, we have made, of course, made clear that uh, use of antibiotic in this country should be very cautiously. Any quinolone should be reserved for the of course, important disease, that is treatment of multi-drug resistant tuberculosis. We should not, because of the tuberculosis, there is a close association. Usually we use oral steroid more and more frequency in COPD cases. There are more risks for developing pulmonary tuberculosis also. And in this country, every cough and dyspnea is not COPD. It may be pulmonary tuberculosis also. So you have to rule out by two sputum examination. As the brand ambassador of a TV says, दो हफ्ते की खांसी है तो दो बलगम की जांच कराएं, अमिताभ बच्चन जी. तो 2 हफ्ते की खांसी can be because of so many reasons, and that's why it is very difficult to reserve these quinolones, and that's why we should not use quinolones for the management of COPD exacerbation. For COPD exacerbation, we have so many antibiotics, and we will discuss just now. But please don't misuse any fluoxacin, ciprofloxacin, levofloxacin, gatifloxacin, moxifloxacin, any floxacin. We should not use in cases of acute exacerbation of COPD.
So you said, sir, that we have many antibiotics. Let me come to one
Yeah.
antibiotic, a very old antibiotic. We call it
Yes.
an antibiotic with midlife maturity and
Yeah.
maiden charm. Midlife maturity because it was approved in the USA in 1967. So now it's
Yes.
55 years old.
Around 50 years back.
Yeah,
Yes.
55 years old next year. So that is midlife maturity. And
Yes.
maiden charm because it continues to exude maiden charm. We keep on learning newer and newer things about its mechanism of action and about its spectrum of action. So the question is, can I use doxycycline as monotherapy in a patient with acute exacerbation of COPD?
You see, again, I will go to the Indian guideline. If you see the management part, that table, that patient of COPD will have exacerbation, can have the, of course, the can be treated in outdoor or can be treated after hospitalization, depending upon the severity of the disease. And the second issue is whether associated with any comorbid condition or not. So these are the two important diseases, whether you are treating COPD or exacerbation as a OPD patient or hospitalized patient or IPD patient, or whether this is patient a purely COPD patient exacerbation or this is associated with some comorbid condition like heart disease, diabetes, and so many others. Now, if you are treating the patients on OPD basis, yes, or you are treating indoor patients, roughly, if you see the spectrum of doxycycline, it's a wonderful drug. We have experience of using this drug for more than 50 years in the globe. That's a great experience. We don't have the experience of other antibiotics for a such large period. Number one. Number two, it has is a spectrum is of course for gram positive, for gram negative, and for atypical bacteria also. So that's a wide range of, you see the spectrum. Number two. Number three, it's a very cheaper drug. Number four, it is available widely even at the remote places. If our general physician is practicing as a tehsil label or block label or at a PSC level or a CSC level, it is freely available in that place also. And everybody as a general physician is available of using doxycycline in different conditions. So even with simple acne, you see most of the practices, most commonly prescribed antibiotic for the skin, one dermatologist, for the gynecologist, and so many other diseases that is being prescribed. For COPD also, yes, it can be used as a monotherapy. It can be used monotherapy because it covers the gram-positive, negative, as well as the atypical. And roughly 25% of COPD exacerbations, they are associated with the atypical pathogens also. So I think it's a wonderful drug. It can be used as a monotherapy also.
So, wide spectrum of action, easy
Yeah.
availability, easy access,
Yeah.
easy affordability, and also the
Cost
fact that
effectiveness, yes.
we've been using it for over 50 years now across the world.
Yeah.
And we have so much of evidence related to it. We can use it
Yes.
as monotherapy, sir. But can I use it along with another bacteriostatic antibiotic? Can I use it along with another bactericidal antibiotic? And what would your
Yes.
commonest partnership be? Would it be a macrolide? Would it be something else when we use doxycycline?
Usually, if you see the antibiotics, they are the choice of combination with the doxycycline. Or if the patient is hospitalized, then it can also be used with the cephalosporin. So for both drugs, it can be used either with the, of course, the amoxicillin or amoxiclavulinic acid if you're using, or you are using the cephalosporin, any generation cephalosporin. So that's a wonderful drug you can use in this combination. No problem.
Apart from uh, antibiotics, many times we have to use steroids in COPD.
Yes.
So if I have a
Yes.
patient on systemic steroid therapy, Then is doxycycline a safe drug, or are there any things I should worry about?
The most important thing is that usually we antibiotic use for 7 to 10 days, but this doxy can be used up to 1 month, 4 weeks. So that's wonderful drug. It can be used up to 1 month also, very safe and quite effective along with the steroid also. It has got antibiotic property, it has anti-inflammatory property, it has immunomodulator property, and it has some anti you see parasitic property also. It can be used in malaria like drug disease like malaria also. So it's a multifaceted drug. It has got, जैसे हम कहते हैं ना भगवान एक है वैसे ब्रह्मा विष्णु महेश 3 रूप हो सकते हैं, इसके तो 4 रूप हो सकते हैं. So it can be used as a antibiotic, of course, the immunomodulator, anti-inflammatory. So it's a wonderful use if you are using the long-term steroid. For example, if a patient in exacerbation, and first choice, of course, the two important drugs which are used for the management of COPD exacerbation are the antibiotic and steroid. So oral steroid and antibiotic, they are the good, of course, wonderful package, drug package for the treatment of acute exacerbation of COPD. If, of course, they are not required oxygen, then oxygen becomes the third drug. And of course, fourth is the important aspect is the treatment of other comorbid condition or other associated extrapulmonary manifestation. For example, pulmonary of heart or so many other things. So these are the four components of treatment of acute exacerbation of COPD, and it's a very useful that if you combine with the steroid, this doxycycline, so it's a wonderful drug along with the steroid also.
So not only does doxycycline have a wide spectrum of action, it has a wide spectrum in terms of how you can use it. You can use it as monotherapy. You can use it along with a cephalosporin or a beta-lactam antibiotic. You can use it along with a steroid or separately. You can use it for a week or even for a month. So I think that is something that makes it easy for us to use. You have a wide variety of ways in which you can utilize the benefits. And not only are the benefits antibacterial, they are also immunomodulatory. Sir, in diabetes, we speak of something called metabolic memory, which means that if you control glucose today with the right drug in the right manner, you get long-term benefit. Is there something known as microbial memory? Now, one bad kind of microbial memory is that I give maybe levofloxacin for 3 days or 4 days, fix up the fever in the short time, but after 2 years, now I'm stuck with a resistant bacterial infection or with tuberculosis, which is not going to respond. That is a bad microbial memory. Does doxycycline have a good microbial memory in terms of preventing future exacerbations?
Yes, that's also a good thing. And we are, of course, we are doing also. You are the best expert for the metabolic memory. I'm not the expert for the commenting on metabolic memory. But yes, antibiotic memory, yes. So doxycycline has got positive metabolic, memory for this antibiotic use. Yes, we can use for the prevention also. And so many times, any patient who is having exacerbation for more than 2 per year, so such type of COPD patient, they can be given during the winter, during change of season, as a prophylactic antibiotic also with long-term memory. Yes, they can be given. This can be given.
So because it is bacteriostatic, you can use it for treatment as well as for prevention. You spoke, sir, that 25% of all the infections are atypical. So what is an atypical pneumonia, sir?
Actually, atypical pneumonia, which is not having the presentation like a classical pneumonia. Classical pneumonia is having high-grade fever, acute presentation, lobar involvement in the anatomical form of the lung. And of course, this is the usual presentation. But in atypical pneumonia, usually onset is sub-acute. It's not an acute onset, number one. Usually fever is not so high. And of course, usually presentation is not so red hot type or acute type. And more so ever, if you see the chest X-ray, in place of lobar pneumonia, means one lobe of the lung is involved for usually upper zone, upper lobe, or lower lobe or middle lobe or whatever it is, but usually has a diffuse involvement. Can be the bilateral involvement, can be the patchy infiltration. So these are some different, and they can be associated with extrapulmonary symptom also. They can be associated with rashes, they can be associated with diarrhea, they can be associated even some neurological manifestation. So this is for example, the chlamydia, legionella, chlamydia, legionella, most commonly, usually atypical, the microbes that is usually complicating the So they can be pure atypical pneumonia presentation, or they can be combination of typical and atypical. So once the patient is presenting typical, that doesn't mean that the flora does not have the atypical, can have. That's why I said 25% maybe the combination of this. Sometimes we can have the pure atypical pneumonia presentation because of these organisms.
What are the antibiotics of choice for atypical pneumonia in the OPD setup?
Yes. It is again the doxycycline, which is covering all atypical pneumonias and very effectively. But only thing is that duration should be prolonged. In place of 7 to 10 days, it can be prolonged up to months.
We have spoken so much about, sir, about the benefits of doxycycline, a really wide spectrum of action, and
Yeah.
something that we can use safely. But any caveats that we should be aware of? Maybe GI side effects. Is it safe in liver disease and kidney disease?
Yeah. That's the beauty of doxycycline. It is safe as far as GI system is concerned. It is safe as far as liver is concerned. And most important, people are afraid of. Once you said, I am having renal disease, do you see general physician or even pulmonologist? Yeah, take the opinion from nephrologist. I am not the right person to use antibiotic. So this is very important, but it is safe in liver disease also. It is safe with GI disease also. It is safe with renal disease also. So that is the beauty of this drug, doxycycline. It's a wonder drug, and of course, most experienced drug, and it can be used in even renal compromised patients.
Doxycycline has got a compensatory mechanism of excretion. So if your kidney is
Yeah,
doing okay, the kidney will excrete it. If your
yeah,
kidney is not able to metabolize, the feces will excrete. It will go out through the gut.
yes, yes,
In this way, it is similar
yes,
to another drug that we use in diabetes, which is linagliptin. Sir,
yeah,
I understand that we have overshot time, but if you could take two questions. One is from Dr. Noor Aga.
yeah,
Dr. Noor Aga पूछ रहे हैं कि one of my patients, a 50-year-old lady, is on oxygen for the past 6 months post
yes,
COVID-19. She requires
yes,
1 liter oxygen per day. The moment
yes.
she stops the oxygen, it drops to 80%. No history of premorbid disease, premorbid asthma before COVID-19. So, what do we
Yes.
do, and what is our target of therapy in such a lady?
Actually, in such type patient, we have to see the post-COVID pulmonary complications. So I think a CT scan, she must have done the CT scan, and we should see what is the area of involvement of lung. And if the patient is having, even after 6 months, the dyspnea, so this is the case of post-COVID pulmonary fibrosis. And we should take the opinion of any pulmonologist that whether we can start any antifibrotic drug in this patient or not. Once you start the antifibrotic drug, the process of fibrosis stops and the patient will respond, and you can take off the oxygen.
So, post-COVID rehabilitation will actually help, and we do have drugs
Yes,
that are available. Dr.
yes.
Rameshpal
So
Singh Pawar is a senior pediatrician. He asks you, sir, what is the minimum age in children above which I can start doxycycline in
yes,
children?
that's also a wonderful question. And although I'm not pediatrician, but if I remember exactly, so I think it can be given in the children above the 6 years, no problem. You may correct if I am wrong.
Yeah.
I think
Thank you, sir. And one last question from Pinky ji. She had swelling feet.
yeah,
Pinky ji, two other things you should look for. Maybe you are taking too much of salt or too little of protein. And if you have lost 20 kg weight, I have a
yes,
feeling you are protein
yes,
deficient. If there is no protein in the body,
yes,
certainly you will have swelling in the feet. So that is one thing we should focus on.
yes.
She asked if she should get a test done for
Yes,
tuberculosis. Yeah.
yeah, she should
She's
have the
asking
serum
if I
protein level and of course albumin globulin ratio, and this can be the one of the important cause because she has lost the weight. So yes, hyperproteinemia can be another cause for the swelling in feet, and she must be investigated for serum protein level.
but if there's 20 kg weight loss, Pinky ji, then we should actually show a pulmonologist.
Yes.
Dr. Amit Patel is a pharmacologist. He reinforces what you said about doxy having anti-inflammatory properties, and he asks you,
Yeah.
what are your comments on antibiotic stewardship? A message for all Indian practitioners.
Actually, antibiotic stewardship is number one, use antibiotic judiciously. In this country, most of the time, antibiotics are mostly, of course, not judiciously used. Every fever on first day does not require any. So at least patient should have patience and doctor should have patience. Both should have the patience for at least 48 to 72 hours. So after 48 hours, you should start investigating patient, or even first visit, you should start investigating the patient. You will try to find out the cause. कारण है तो निवारण ढूंढ पाएंगे. So try to find out the cause, and then accordingly you can use antibiotics. So don't use the antibiotic non-judiciously, which is a common practice in this country. And this is the season of viral illnesses and mostly fever because of the viral diseases. So just wait and watch. And if you are convinced that this is the viral disease, because viral infections usually are self-limiting or usually require paracetamol, bed rest, and water. That's all. The three things are required for most of the viral diseases. And of course, fourth is the patients. Patients from the patient side also, patients from the doctor side also. So that is important. The second thing is, if you are practicing in ICU or hospital, you should have your antibiogram. You should have repeated culture of your OPD, your lab, tubings, ICU apparatus, so that you can have the antibiogram of your local hospital profile, and you can use the antibiotic according to that. And third, fourth important thing is the previous response to antibiotics. So that's important. आप पूछिए भाई पिछली बार आपको ये जो COPD exacerbation हुआ था हमने कौन सा एंटीबायोटिक दिया था. If you have the patient have the prescription, you can see, and usually same type of antibiotic should be used again. So I think if you remember these four principles, and of course you can choose antibiotic judiciously.
So we've learned a lot from you, sir. We've learned about COPD, acute exacerbations of COPD. We've also learned about atypical pneumonia. And I suddenly realized that we've learned three pillars of microbial memory from you. The first pillar is when you misuse antimicrobials, and then your patient and the entire community gets into trouble a few years later because there is a lot of resistance. That is a bad kind of a microbial memory. The second one is when you use a drug judiciously, like maybe doxycycline, and you are able to postpone or prevent or delay acute exacerbations. So you're able to prevent a lot of unwanted morbidity. And the third one is what you said just now. If you do have microbial memory, in the sense that the patient and you document properly and you remember what worked last year and what didn't work last year, that will help you achieve faster and more efficient control with the next exacerbation. That is also a type of a microbial memory. Ashutosh ji adds to that you can use doxycycline actually in gynecology, in dermatology, and in dentistry. So it has a wide spectrum of action, wide methods of usage, and across the body, across all organ systems, it can be used. Dr. Suryakant, I'd like to thank you a lot. Thank you very much for being with us today. We've learned a lot from you. On behalf of
we
Dr.
always
K.K.'s
enjoyed your moderatorship. You are a wonderful moderator, and thank you, IJCP, MedTalks, and of course the whole team of Dr. K.K. Agarwal. Thank you very much.
We'd like to thank everybody who is logged in with us today. Together, let's work hard to make India a happier and a healthier nation. Jai Hind.